Hello, my name is Samantha Bentley, and I will be talking about case 1 and case 2. So the diagnostic test that I believe would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation would be a test for urinary acids, which is choice B. The urea cycle is important because when it's functioning properly, it is essential for the disposal of nitrogen from catabolic processes. It functions independently from hormonal control and disposes of nitrogen from either dietary sources or protein catabolism. So one indicator of dysfunction in the urea cycle is elevated levels of ammonia, which it can become life-threatening if it goes untreated. So if these ammonia levels are high, it's indicative that there is a deficiency in the ability to dispose of that ammonia through the urea cycle. Another urinary acid that you can look at when distinguishing if there's a deficiency in the urea cycle is urine orotate, which comes from an alternative pathway that accepts carbamoyl phosphate, which is used in pyrimidine synthesis. So if those levels are low, then it would suggest that there is not an accumulation of carbamoyl phosphate. In addition to the urine orotate, you can also look at blood citrulline levels and blood arginine levels. And then when you're looking at all 4 of these together, you can get a pretty good idea of where the deficiency lies in the urea cycle. So if there is a deficiency in beta oxidation, you would want to run a test for blood glucose levels because a deficiency in beta oxidation can result in hypoglycemia due to the inability to support glucose synthesis. Running a test for serum fatty acids wouldn't be indicative of a deficiency in the urea cycle or beta oxidation for that matter, but rather to determine if levels of the beneficial fatty acids are adequate. A test that measured plasma glutamine would more so likely be done to measure the amount of amino acids in the blood. So an increase in plasma glutamine might be indicative of a deficiency in the body's ability to metabolize those amino acids. And then on the other hand, if there's a low plasma glutamine level, it could be suggestive of inadequate nutrition, fevers, and other medical conditions. So a diagnostic test would not be a good way to, diagnostic test for the plasma glutamine levels would not be a good way to tell if there's a deficiency in the urea cycle compared to testing levels of the urinary acids. So in this specific case, the blood ammonia and urine orotate levels are both elevated, but the blood citrulline levels were around normal. So I believe that this would be characteristic of an ornithine transcarbamylase deficiency, or OTC. Elevated levels of the urine orotate is suggestive of an increase in production or accumulation of the carbamoyl phosphate, which I did talk about earlier. So this in combination with the elevated levels of ammonia would suggest that the carbamoyl phosphate synthetase is active and producing the carbamoyl phosphate. However, since the urine orotate levels are high, the carbamoyl phosphate is accumulating, which means that the ornithine transcarbamylase is deficient. So this would explain why the infant in this case has lethargy, hypothermia, and apnea, as these are all signs of an OTC deficiency. And lastly, since the blood citrulline levels were around normal, the enzyme arginine synthase is the least likely to be impaired. A deficiency in this enzyme would result in increased levels of citrulline, which is not the case. Arginine synthetase adds the second amino group from aspartate with the citrulline to form arginosuccinate, which then goes on to be cleaved into fumarate and arginine by arginosuccinate lyase. All right. Now moving on to case 2. So phenylalanine is an essential amino acid, and the hydroxylation of phenylalanine is done by phenylalanine hydroxylase, which then results in the production of tyrosine. So this conversion requires tetrahydrobiotin, or BH4, as a cofactor. Phenylketonuria Ketonuria, or PKU, is caused by deficiencies in either this cofactor, the BH4 cofactor, or the enzyme phenylalanine hydroxylase. So as a consequence, if someone does have this deficiency, tyrosine may become an essential amino acid, which means it then need to be supplied by an exogenous source. And tyrosine is important because it's required for the production of melanin, and it's also a substrate for thyroid hormone synthesis. So PKU is an inherited disorder that is caused by mutations in the phenylalanine hydroxylase gene, which provides instructions for making phenylalanine hydroxylase. And the phenylalanine hydroxylase is important because it converts the phenylalanine to other compounds used in the body, such as the tyrosine that I was just describing. And if there's a mutation that reduces the activity of the phenylalanine hydroxylase, then the phenylalanine that's coming in from the diet is not processed effectively, and this results in accumulation of the phenylalanine in the blood, which can be very toxic if it goes untreated. So the signs and symptoms of someone who has PKU varies largely. It can be very, very mild to severe. And in infants, the symptoms don't typically appear until they're about a few months old. And if they go untreated, it can develop into permanent intellectual disability because the nerve cells in the brain are particularly sensitive to levels of phenylalanine. In addition, other symptoms could be delayed development, seizures, behavioral problems, and psychiatric disorders. Also, infants who are born to mothers who have PKU have a significantly higher risk of intellectual disability because they are exposed to those high levels of phenylalanine before birth. But in this case, the parents deny any family history of PKU. In regards to the PH4 loading test that was done in that graph that is shown, so both patient A and patient B started at around the same levels. And then after 4 hours, and then again after 8 hours, blood was drawn, and you can see in patients B levels of phenylalanine, it begins to decrease, and then it begins to decrease even more so after 8 hours. And these BH4 loading tests are a way to decrease high levels of phenylalanine in an individual with PKU, which this can be beneficial because it can eliminate the need to have phenylalanine restrictive diets, which has been shown that individuals have a very hard time adhering to these diets, and so it's not really effective, especially in the cases where you have mothers who are becoming pregnant and they don't know that they have PKU, and then it's then affects their babies. So in patient A, however, the phenylalanine levels begin to increase after 4 hours and then continues to increase after 8 hours. So comparing the two, it tells me that patient A didn't have a deficiency in the BH4 cofactor, or it could just be that it didn't respond well to the BH4 treatments. And the patient could have a deficiency in the phenylalanine hydroxylase, which would be an explanation for why they have high levels of phenylalanine in their blood. But patient A did respond well with the dietary restrictions, which showed that their levels the phenylalanine levels came back down to normal after doing that for 14 days. And this is a good indicator that they were able to catch the high levels of phenylalanine early in the infant's life, because in the beginning it said that the infant was only 4 days old when they started this, and they were effectively able to treat it right away. All right. Thank you.